Okay, I'm going to go ahead and get started. I'm going to talk today about temporomandibular dysfunction as a sequela of traumatic brain injury. My advisor was Dr. Watanabe. So quick outline, go over the learning objectives, introduction, etiology, diagnosis, and then focus mostly on anatomy, biomechanics, and then treatment options for temporomandibular dysfunction. So learning objectives for this talk will be to review the anatomy and biomechanics of the TMJ and how it relates to etiology of temporomandibular dysfunction, review the signs and symptoms of TMD and when to consider the diagnosis in an individual with traumatic brain injury, and then to explain bruxisms and oromandibular dystonia as a potential cause of TMD following traumatic brain injury, and then to review treatment options. So temporomandibular dysfunction encompasses a collection of conditions involving the temporomandibular joint, the masticatory muscles, and the surrounding tissue structures. It's associated with substantial morbidity and affects individuals' work productivity and quality of life, mostly related to pain. And it's estimated that for every 100 million working adults, TMD contributes to 17.8 million lost work days annually, again, mostly contributing to the pain component. So in traumatic brain injury, TMD can result from or be exacerbated by direct or indirect trauma to the joint. And sort of just a little bit of why I chose to talk about TMD in the TBI block it was the relationship that I found between TMD and psychiatric disorders or neurological disorders, TMD with bruxisms and oromandibular disorders, which are common in TBI, and I'll talk more about that. And then, as we all know, post-traumatic headaches are one of the most common symptoms following a head injury. And TMD can be a cause of post-traumatic headaches, and there are treatment options that are available. So in doing this research, I found this paper that I thought was interesting. In 2007, the Office of Army Surgeon General established the Propency Office for Rehabilitation and Reintegration, and it looked to establish best practices and policies for injured service members, looking at recommendations for interventions for post-TBI signs and symptoms in this population. And some of the things that they were focusing on I thought were pretty obvious, like vestibular dysfunction, balance dysfunction, post-traumatic headaches, but temporomandibular disorders were also included in that those recommendations. And so potential etiologies for TMD related to traumatic brain injury. So in the general population, TMD is likely multifactorial in many cases. Systemic diseases can play a role, such as arthritis or infection. People with poor dental health or dental malocclusion can cause TMD. And then psychosocial factors, like we all know, stress, and then local stressors, most commonly repetitive microtrauma from such thing as biting nails or habitual teeth clenching or people who chew gum. There's a relatively high prevalence, 25 to 55% in the general population, but 1 in 4 patients with TMD has a history of head or neck trauma in proximity to the development of symptoms. So following traumatic brain injury, temporomandibular dysfunction can result from direct or indirect trauma to the joint. So direct injury, secondary to penetrating or blunt trauma is pretty obvious. There can also be fractures, iatrogenic injury, and then indirect trauma, such as myofascial dysfunction and repetitive microtrauma. So fractures and temporomandibular joint ankylosis, following blunt trauma to the head, to the face, mandible fractures are pretty common. 26 to 40% occur at the condyle or subcondylar region. And that's the component of the mandible that is part of the temporomandibular joint. So traumatic fractures of the mandibular condyle are a common cause of TMJ ankylosis, and TMJ ankylosis is sort of the most severe manifestation of TMD, causing stiffness and immobility of the joint. So 2 studies looking at post-traumatic TMJ ankylosis. It's common following fractures of the mandibular condyle, but the pathogenesis is still poorly understood. So there were 2 studies that looked at potential pathogenesis factors. So this first study found that There were sears, injury to the articular disc, and capsule of the TMJ was a major contributing factor towards the development of joint ankylosis after closed reduction of condylar fractures. And closed reduction of condylar fractures is the most common way to manage these fractures. So I guess if you have a patient who has had a fracture to the joint, to the condyle, and has had closed reduction, it would be worth considering TMJ ankylosis in the future. And then this other study was a smaller study by Ferretti looking at 26 patients, and he found that medially dislocated condylar fractures were more often associated with TMJ ankylosis. So this isn't a great image, but this is just an image showing a condylar fracture, and then this is an external fixation of a mandible fracture, which would obviously, you could see how that would cause dysfunction of the TMJ. So iatrogenic injury is also a potential etiology for TMD following traumatic brain injury. Damage to the joint during necessary management or treatment post-TBI can affect the joint. So craniotomies or craniectomies are particularly involving the temporal bone. If patients are intubated, especially for prolonged periods, if they require dental procedures, and management of mandibular fractures, as I just discussed, are potential causes. Myofascial dysfunction is overall the most common cause of temporomandibular dysfunction. Results from direct or indirect trauma to the muscles of mastication, and it's usually exacerbated by repetitive use or overactivity of the jaw muscles, such as teeth clenching, grinding, chewing, or mandibular dystonia can also, and bruxisms can sort of have a cause and effect relationship with myofascial dysfunction. So the proposed pathophysiology for myofascial dysfunction, you have soft tissue damage leading to local tissue destruction of the muscle ligaments and tendons, which leads to neurovascular disruption, and then the affected myofascial structures respond with increased tone or muscle spasms. And the theory of myofascial dysfunction and muscle hyperactivity leading to fatigue, spasms, and pain, triggering further myospasms, resulting in this positive feedback loop, was described by Dr. Janet Travell as trigger points. So repetitive trauma is also an obvious cause of potential cause of temporomandibular dysfunction. This study looked at TMD in boxers, and it found evidence of increased mechanoexcitability over the masseter muscles, with concomitant hypersensitivity of the trigeminal nerve in boxers with TMD, and this suggested a sensitization process may be involved in the development of TMD following repetitive trauma. So repetitive microtrauma, I'll talk about two examples, specifically relating to traumatic brain injury individuals. Excuse me. So bruxisms are an involuntary form of dystonia characterized by excessive teeth grinding and jaw clenching. It's commonly seen following traumatic brain injury, and it's thought to be related to an impaired sleep-wake cycle and altered levels of consciousness. As levels of consciousness improve, bruxisms tend to improve. But if left untreated, bruxisms can lead to muscle hypertrophy, headache, dental wear, and TMD. Oromandibular dystonia is another cause of repetitive microtrauma in this population. So it's a focal dystonia that occurs following TBI, and it results in spasms of the muscles of mastication, the tongue, and the muscles of the lower neck and face, and it manifests with orofacial disfigurement, pain, trismus, and TMD. So just a kind of a summary of some of the signs and symptoms in TMD, and when you might consider TMD as a cause of a patient's symptoms following traumatic brain injury. So pain can be anywhere from headache, ear pain, pain in the teeth, sensitivity to heat and cold, in the teeth, in the pain in the face. Pain is generally dull and achy. It's exacerbated by chewing, yawning, talking, can radiate to the neck and shoulders. You might have ear pain or tinnitus. People can complain of dizziness, patients might complain of impaired jaw mobility or jaw locking with difficulty opening and closing the mouth, and noises heard when with jaw motion. And then just a couple things to kind of consider when you're considering the diagnosis of TMD would be not only looking at the associated symptoms, but the mechanism of the injury. Is this a repetitive trauma? Was this a motor vehicle accident with a concomitant whiplash injury? And obviously the severity of the injury. This is a mild head injury versus a severe injury is going to guide your treatment options. So anatomy and biomechanics of the temporomandibular joint. So the head of the mandible articulates with the mandibular fossa, and then you have a biconcave articular disc separating the joint. The TMJ is unique in that it combines both a gliding joint and a hinge joint. The gliding mechanism allows for the forward gliding or protrusion of the mandible in relation to the temporal bone, and then the retraction. And then the hinge mechanism allows for closing or elevation and opening or depression of the jaw. The muscles of mastication, the temporalis, masseter, lateral pterygoid, and medial pterygoid are involved in functions of the temporomandibular joint. So the temporalis muscle originates on the temporal fossa and then inserts onto the coronoid process of the mandible and anterior margin of the mandibular ramus, and it acts to elevate and retract the jaw. So it closes the mouth. The masseter muscle originates on the zygomatic bone and then inserts onto the lateral surface of the mandibular ramus, and it acts to elevate the mandible. And the masseter muscle is one of the strongest muscles in the body, owing to the fact that it has a mechanical advantage of a very short lever arm. The medial pterygoid originates on the pterygoid process of the palatine bone and the pyramidal process of the maxilla, and then inserts onto the medial side of the angle of the mandible. And then it acts to elevate and protrude the mandible and provide side-to-side movement. So the lateral pterygoid originates on the superior, or the greater wing of the sphenoid, and then the lateral aspect of the pterygoid plate, and then inserts onto the, actually onto the joint itself, onto the articular capsule of the temporomandibular joint and the pterygoid fovea on the neck of the mandible, and it provides protrusion and side-to-side movement of the mandible. And then I think I show this image again later on, but this I wanted you to see the relationship between the pterygoids from this view, so you can see how an intraoral approach would be possible to palpate the medial and lateral pterygoids. And then just a summary again of the muscles, so the temporalis, the masseter, and then the lateral and medial pterygoid. And then a summary of the anatomy and biomechanics. So protrusion of the mandible is achieved by the lateral and medial pterygoids, retraction, the temporalis and masseter, elevation with the temporalis, masseter, and medial pterygoid, and then depression mainly with gravity, as well as assistance from the digastric, geniohyoid, and mylohyoid. So examination of the temporomandibular joint it kind of follows the same principles as examining any other joint in the body. You're going to look at static and dynamic evaluation of the joint, surrounding structures. An individual should be able to insert 2 to 3 knuckles in a maximally open mouth, which is approximately 40 millimeters, and deviations of the mandible from midline when opening and closing the jaw suggest asymmetric tone in the pterygoid muscles. Palpating the temporomandibular joint can be achieved by palpating through the external auditory canal, and as the patient opens and closes the jaw, you'll be able to feel clicks or asymmetric movements in the joint. And this is my halfway point. I think I'm doing all right. I didn't talk about imaging, but there are all, you know, CT imaging, MRI to look at the myofascial structures. Ultrasound is kind of limited with the joint based on the fact that you're not really going to be able to see the more superior aspect, but it is possible. Okay, so treatment of temporomandibular dysfunction. You can use manual therapy such as osteopathic manipulative techniques, physical therapy, medications, oral and injections, oral splinting, and then behavioral and dietary modifications, and surgical interventions are also kind of your last resort. So review of trigger points and tender points before we go into treatment options. So palpation of the muscles of mastication can be used to identify trigger points or tender points. And just briefly, the difference, a tender point is more of a local area of focal tenderness without radiation or referred pain patterns, whereas trigger points are these hyper-irritable spots in skeletal muscle associated with a hypersensitive palpable nodule. They're tender when pressed and can give rise to characteristic referred pain patterns, motor dysfunction, and autonomic phenomena. The management of trigger points is important to identify and, if possible, eliminate any predisposing or perpetuating factors in chronic overuse or stress of the muscles. So if you're treating a trigger point in a patient who has bruxisms, trying to find other ways to sort of manage the bruxisms might be difficult, but it's just important to consider what factors are exacerbating the trigger point. Manual therapy can be helpful in the acute phase, but trigger point injections may be indicated in patients with symptomatic active trigger points that are creating those referred pain patterns. And in comparative studies, dry needling was found to be as effective as injecting an anesthetic solution into the trigger points. So temporalis tender point. To locate the tender point, you apply medial compression along the muscle, allowing for identification of tender, thick, raised areas. If you clench the jaw, you're activating the muscle, and that can help to identify not only the muscle, I mean, the muscle's pretty obvious to identify, but just the tender points. And then this lady here, she loves counterstrain. She, so one technique for treatment of a tender point would be temporalis muscle counterstrain. And so the general principle for counterstrain is you want to bring the muscle into a relaxed state, and then you hold that position for 90 seconds, release and recheck, and you always want to be monitoring the point. So with one hand, you're monitoring the tender point. So that's here, he's monitoring the tender point, and then gently pushing the relaxed jaw toward the affected side so that you're bringing the origin and insertion of the temporalis muscle closer together. And alternatively, or in addition, you can apply sort of a downward compression, or by gliding the fascia of the scalp of the temporalis muscle inferiorly towards the temporomandibular joint. And then this is from Travell. So these are the temporalis trigger points and referral patterns. So these are the trigger point locations, and then how the pain patterns would be referred are in red. So with the temporalis, it's pretty broad. You can have pain diffusely in the face or jaw, sensitivity to heat or cold in the upper teeth. So the masseter muscle, to locate the tender point for the masseter muscle, you would press the muscle anteriorly, locate the muscle anteriorly, and then press posteriorly. So you're not pressing directly over, but more anterior to the muscle of the masseter muscle. And then counterstrain technique for tender points, monitor the tender point with one hand. So that's here. And then again, you're shortening the distance between the origin and insertion. So you're applying a sort of a lateral glide towards the affected side of the mandible. Hold for 90 seconds, release and recheck. And then masseter muscle trigger points and pain patterns, not as diffuse as the temporalis muscle, can have involvement over the eyebrows or lower jaw, but the deeper tender points or trigger points in the masseter muscle can actually cause tinnitus. So intraoral palpation of the medial and lateral pterygoids is the most efficient way to locate these muscles. So I'll just go to the slide. So you're sliding, if the jaw is open, you're sliding your finger back along the teeth and then turning the pad of the finger superiorly and laterally to locate the medial and lateral pterygoid, and having the patient protract the jaw will differentiate the lateral pterygoid from the medial pterygoid, because the lateral pterygoid would be active as the jaw is protracted. And then this is just showing sort of what that looks like. And if you've ever had this done or do this to a patient, this is what they look like, because it's painful. And then for the trigger points for the lateral pterygoid, again, more specific than the medial pterygoid, over the zygomatic bone and then anterior to the tragus. And then for the medial pterygoid, more in front of the ear is where those trigger point patterns are going to. So the medial pterygoid tender point. So again, the medial pterygoid inserts onto the medial aspect of the angle of the mandible. So the tender point is located on the posterior surface of the ascending mandible, about 2 centimeters above the mandibular angle, so sort of back here. And you palpate this point by pushing anteriorly. And then the counterstrain technique for that, you again, you locate the tender point, monitor with one hand, and then you're going to move the jaw away from the tender point, because the insertion is on the medial side of the mandible as opposed to the lateral. So if you're moving it medially, then you're shortening that muscle. And then medial pterygoid muscle energy technique. I couldn't find a good image of this one, but so muscle energy techniques are used to treat muscle hypertonicity using isometric contraction. Observe the patient slowly opening and closing the mouth to note any deviations of the mandible. And then as the patient opens the mouth, you grasp the mandible with the thumbs inside the mouth and then the fingers wrapped around the outside of the jaw, and then resist that deviation of the mandible as the patient opens, or as the patient closes their mouth. Lateral pterygoid, so a myofascial release technique. You're going to palpate the lateral pterygoid as I previously described, and then as you're standing on the contralateral side to be treated, once you locate the lateral pterygoid, you have the patient turn their head towards you so that the pterygoid drops over the operator's finger, and then that position is just held until that release and tension is felt. So oral medications are also an option in treatment of temporomandibular dysfunction. And again, it's a matter of when the injury occurred, how severe the injury was, that's going to sort of help lead to what your treatment options are. So NSAIDs can be used in the acute phase, generally a short course, like 10 to 14 days, help reduce pain and inflammation. Up-to-date recommended naproxen, 250 to 500 milligrams twice a day. And for patients with pain on palpation of masticatory muscles, it's also possible to add a short course of a skeletal muscle relaxant such as cyclobenzaprine, 10 milligrams at bedtime, again for a short course. I think, and it may also be helpful in those sort of that acute phase, using some of the manual therapies in conjunction with the NSAIDs or muscle relaxants if it's appropriate for that patient. And if NSAIDs or muscle relaxants aren't effective after 2 weeks, adding a antidepressant such as TCAs, which are the most widely studied, amitriptyline 25 milligrams at bedtime. It might take 1 to 2 weeks to see the effect, but you might consider this in a patient who has a component of depression or anxiety following an injury. And then for severe cases, long-acting benzos for short term may also be helpful, such as diazepam. And then NSAIDs, TCAs, and muscle relaxants, although they might be helpful in the acute phase, their efficacy in treating chronic TMD is insufficient. And with the TBI population, it's important to consider their their side effect profile before using these medications. TCAs, you can see cognitive dysfunction, confusion, delusions, headaches, muscle relaxants can cause fatigue, confusion, decreased mental acuity. So these might not be the best options in the TBI patients, especially the more moderate or severe. So talk a little bit about, I feel like I'm talking too fast, I'm sorry. So Botox for treatment of temporomandibular dysfunction, bruxisms, oromandibular dystonias. So following a traumatic brain injury, TMD can result from or be exacerbated by bruxisms or oromandibular dystonias. Botox injections to the muscles of mastication can be a useful treatment options for these patients. Potential side effects include temporary bruising, pain at the injection site, difficulty chewing, dysphagia, and asymmetric facial expressions. So here's your quick board review for the SAEs tomorrow. Botulinum toxin binds to the SNAP25 protein, or on the SNARE protein, a presynaptic membrane protein required for the fusion of the neurotransmitter, and by binding here, it blocks the release of acetylcholine. So botulinum toxin to the temporalis muscle. There are several injection points, superficial and deep, used to adequately weaken the muscle. Superficial injections are performed into the thinner upper regions of the muscle, and there's no specific precautions required. Advancing the needle too deeply can engage the bone and damage the needle, but you're not going to damage any structures. Whereas the deep injections, you do run the risk of injecting into the superficial temporal artery and vein. And then this image here, so these are your more superficial points, and then the deeper point here where you run the risk of injecting into the temporalis artery. And then botulinum toxin to the masseter muscle. It's generally a thicker muscle, so diffuse injections are usually needed. You can use EMG guidance to help target areas of the greatest muscle bulk or greatest discomfort. And anterior superior injections can affect the zygomaticus major muscle, and that results in the inability of the patient to raise the corner of their mouth. So here's your masseter muscle, and then the zygomaticus major here. So if you're injecting into this more superior anterior location, you can affect that, just causing a cosmetic defect. And then this is just an example of some of the potential masseter injection points for Botox. And then again, temporalis injection points, masseter injection points for Botox. And you can also use ultrasound guidance to help with these. So Botox to the pterygoids can also be done. Adequate relaxation of the masseter and temporalis is generally enough to provide pain relief and reduce joint loading, but in some cases, such as in oromandibular dystonia, let's just say, where opening the mouth remains difficult, treatment of the pterygoids can be helpful. And you usually want to treat the masseter and the temporalis first, though. So the medial pterygoid can be injected extraorally via a submandibular route. The angulation limits visibility, and access to the superior aspect of the muscle is limited with this approach. And an intraoral approach allows you to palpate the muscle before injecting, but if the patient has really tight pterygoids, even after relaxation of the masseter and temporalis, so that they still have difficulty opening their mouth, this approach can also be limited. So with the medial pterygoid, some precautions with the Botox injections. Superior medial injections can approach the infratemporal fossa and its contents, so you can inject to the maxillary artery, mandibular nerve, and then inferior medial injections outside the medial pterygoid can affect the submandibular gland as well as the muscles of the floor of the mouth. So an extraoral approach for the lateral pterygoid, you would insert the needle through the mandibular notch. And if you have the patient move the mandible from side to side, that helps to verify needle position. You can do that with EMG guidance. And then intraoral approach, again, requires that intraoral palpation of the lateral pterygoid, but it's generally sort of a blind approach. You're aiming the needle laterally and posteriorly towards the patient's ear. And again, you run the risk of injecting into the infratemporal fossa and its contents. And there's also a pterygoid plexus of veins that surround the muscle. Let's see. So other treatment considerations, so conservative treatments, behavioral, dietary modifications, in general are just important to consider whether you're going to be treating with medications, manual therapy, or Botox, finding things that are exacerbating their symptoms and limiting them. So if they're chewing gum, if they bite their nails, you might want to use some behavioral techniques too. And dietary modifications to help limit those exacerbating factors, and then knowing whether this is a repetitive trauma, such as somebody who's involved in boxing, for example. Oral splinting can be helpful for patients with bruxisms. It can be used as a way to help prevent injury in sports-related injuries. And then surgery is always sort of that last resort. But can be useful, especially in cases of severe TMJ ankylosis. I talked too fast, I'm sorry. So conclusion, so the temporomandibular joint is the most repetitively used joint in the body. It functions in our ability to communicate and eat. It's pretty important. In the traumatic brain injury individuals, you can see this as a manifestation or an exacerbating factor for headaches, bruxisms, or oromandibular dystonia. Manual therapy is a useful treatment for TMD, particularly if identified early in the acute phase. And then Botox and trigger point injections can also be useful in the treatment of these disorders. Any questions?
So I've got a question. I don't have any personal experience yet doing Botox for migraine headaches. I was wondering if you saw any, like, the injection diagrams to show where people typically inject for migraines, to see how much crossover there is between diagnosis and treatment of TMJ dysfunction and migraines, to see how much similarity there is or difference there is in how people.
Not specifically, mine. I did find that like there was, even in the articles that I found talking about treating oromandibular dysfunction and bruxisms and TMD with Botox injections, like most of them focused on the temporalis and the masseter muscles, and then kind of an aside that you can treat the pterygoids. I don't think they're done as frequently, but I'm not, and there was a lot, I did see commonly that they talked about treatment of migraines, but I didn't look into sort of what muscles and were being treated in migraines. Maybe Dr. Wynick can talk more about that.
I treat that migraine as well.
What would you like?
And TMJ. Can you get that picture of where the trigger points are on the mouse?
Yeah.
So I have a pointer with my finger. So you find the hairline, and you move finger breadth to 2 inches from the hairline. You don't want to inject advance of the hairline, because this muscle will atrophy. So you have a little concavity there once you inject it. So it's about 2 finger breadths in, or maybe a finger breadth in. You inject here, you come a finger breadth in front of the ear, 2 finger breadths above that here, so it matches up. These pretty much match up, and then you come over here for another one that lines up at the back of the ear. And those are those 3. 4, sorry, 4. 1, 2, 3, 4. And the masseter I inject as well. So they're similar. And patients will come in, and sometimes they come in with migraines, and you ask them, so, do you have ear pain? With ear pain? And they often say yes. Because you ask them, do you grind your teeth at night? And they usually say, I don't notice I grind my teeth, but my partner does. So it's a good way to do both of them. You could treat it in the office. The first time, you could get a relief with an osteopathic technique. The intraoral techniques, They do hurt. That picture was perfect. That is exactly how they look when you put the finger in them. But the release is pretty interesting. You'll have this hypertonicity of the muscle and you'll hold it. And anyone can develop these palpatory skills. They'll feel the release. And it's incredible. You'll feel the release and they'll tell you, you know, that I can do that now. It's very interesting. As far as doing the turbo, I haven't done those.
Yeah.
I probably may have injected them inadvertently.
You said you could figure them out. That's the terrible.
Yeah, you can feel it soften.
Yeah, I couldn't find any good like images or even
Yeah,
super good
gotta-
descriptions of the injections, but
and it's up higher than you think,
Mhm.
and the pressure is just a steady pressure. You know, you want to make sure you don't have a sharp nail. Please use a glove. If you wet the glove, it goes in a little easier than not. So I thought it was really disgusting. So the powdered glove is even worse. So the thing that it would be nice to do for our journal, you know, we see TMJ, and I just had a patient the other day came in with it as well. We should probably do a little bit of everyone's capturing all the ultrasound guided techniques for every joint in the body. Jason Smith has written something. Probably not the TMJ yet. So we can jump on him if you like. We have 2 good ultrasound machines, including a small hockey stick probe. That would be interesting. We can look at this and just and map it out. And it would be very comprehensive, real quick review paper for either the Osteopathic Journal or the Blue Journal or the Purple Journal. Or if you need, we'll stuff it in the Medical Dental School newsletter. We'll come back. All right. So this is a very interesting talk.
Any other
Any
questions?
numbers on the toxin injections, how effective they were?
So there was one study that I can recall off the top of my head that was 20 units into the temporalis and masseter, and it provided relief of temporomandibular dystonia up to like 3 to 4 weeks.
Like percentage, would it improve?
No, I've found a couple case studies, but I don't think there's been like any large studies on this yet.
Actually, the same question, but for the counter-strength tightness,
Uh-huh.
you know how effective those are usually.
So again, I mean, you know, like osteopathic studies aren't, there's not a lot out there on osteopathic studies.
So
Yeah.
the only thing I'd say about that with the counter strain is that it gives you a lot of quick relief, but a lot of times it's not short, not long.
Not long acting. Mhm.
Solve whatever's causing it.
But I think it would be useful, like if you knew the counter strain techniques or any of the other manual therapy techniques and could, you know, do a Botox injection or a trigger point injection and then use those techniques to allow that muscle to relax, even just temporarily, and allow the medications to kind of get the maximum effect. Am I done?
You're done.
Okay.